4 questions that
Sir, one
been...
more topic is there, sir.
Which one? Which topic is there?
Assessment of airway in TMJ ankylosis, sir.
Okay. Right. Okay. If you are game, we will finish it off. That also. Okay. Who is going to present that? Soundarya?
Yes, sir.
Are you ready? Go ahead, ma.
Yes, sir.
Hmm.
My topic is assessment of airway in TMJ ankylosis. First, what is TMJ joint? It is diorthodal synovial joint. It is craniomandibular articulation. If one joint is affected, ultimate resulting is limited mouth opening. Articular surfaces are lined with fibrocartilage instead of the hyaline cartilage. So, if any trauma will lead to development of fibrosis of the joint. Physiologic functions of TMJ joint is chewing and speech. The movement of joint is hinge-like movement and the sliding movement. In hinge-like movement, the TMJ accounts for 2 to 3 centimeter of mouth opening. In sliding movement, it further 2 to 3 centimeter mouth opening. So totally, the movement of jaw is 4 to 6 centimeter mouth opening should be expected for adequate laryngoscopy. If the patient is having TMJ ankylosis, the classical triad of history of pain in the preauricular area and noises from the TMJ joint in limited mandibular movement. First, we should take a thorough history in the patient. Any previous history of difficult airway, any previous history of surgery, burns, any trauma, any tumor in the oral cavity, any joint movement, any restricted joint movement, facial asymmetry, occlusional defects, and dentitional problems, we should rule out. Assessment of airway in difficult mask ventilation, any presence of bearded, obesity more than BMI more than 26 kg per meter squared, any edentulous, elderly age more than 55 years, any snorers. Physical examination includes assessment of cervical and atlanto-occipital joint function. Ask the patient to touch his manubrium sternum with his chin. It's a neck. It indicates of neck flexion of 25 to 30 degree. And ask the patient to look at the ceiling without raising eyebrows and to test the atlanto-occipital joint function. Assessment of TMJ function. Ask the patient to, that is 2 tests. Place index finger in front of the tragus and the thumb in front of the lower part of the mastoid process begin the ear. Ask the patient to open his mouth wide. The condyle of the mandible slides forward if it is indicating the good sliding function of the mandible. Hello, sir.
Yeah, go ahead.
Yeah. Upper lip bite test. For the upper lip bite test, patient is asked to bite the upper lip. If it's classified as the class 1, 2, 3. Class 1 is lower incisor bite above vermicular border of upper lip. Class 2 is lower incisor bite vermicular border of upper lip. Class 3 is unable to bite upper lip. Second test is jaw protrusion. Ask the patient to protrusion jaw protrusion to open their mouth fully and then push their lower jaw forward. Grade A is lower teeth can be moved in front of the upper teeth. Grade B is lower teeth can be placed in line with upper teeth. Grade C is lower teeth cannot be placed in line with upper teeth. Then neck mobility, the range. Assessment of mandibular space. Thyromental distance, the distance between the thyroid knots and mental symphysis with when the neck is fully extended. More than 6.5 centimeter is normal. If it is less than 6 centimeter, impossible to do laryngoscopy. Hyomental distance, the distance, this is the distance between the mentum and hyoid bone. It is normally in 6 centimeter. If it is less than 4 centimeter, it is impossible to do laryngoscopy. For assessing the adequacy of oropharynx, we should evaluate the Mallampati grading, grade 1, grade 2, grade 3, grade 4. Grade 1 is visualize the pillars, uvula, soft palate, and hot palate. Grade 2 is uvula, soft palate, and hot palate. Grade 3 is base of the uvula and soft palate to hot palate visible. Grade 4 is only hot palate is visible.
Soundarya, I think you have mistaken the question. The question itself says assessment of airway in a patient with TM joint ankylosis, isn't it?
Yes, sir.
That means you pretty well know that patient cannot open the mouth, isn't it? The most important clinical finding you will have in a patient with TM joint ankylosis is inability to open the mouth, isn't it?
Yes, sir. Yes, sir.
Then how will you go and describe Malambatti, upper lip bite test and all these things? So here that is a catch in the question. If you start writing how you assess the airway in a patient who can fully open the mouth, that is totally not applicable to the patient who has a TM joint ankylosis, whether it is a unilateral or a bilateral joint ankylosis. If it is unilateral, he may hardly have 1 centimeter interincisor distance, or at the most 1.5 interincisor. I will show you pictures how much opening will be there. So when the mouth opening is totally not possible, the mandible protrusion test or the finger insinuation test, everything becomes inapplicable to them, isn't it? So here your aim must be to identify whether you can succeed in, as we saw in the earlier description, discussion with nasal intubation. One of the indications for nasal intubation is TM joint ankylosis with trismus, where the mouth opening is totally restricted. So here your airway assessment should focus more on how you are going to succeed in doing a nasal intubation, whether awake or with a fiber optic, awake fiber optic intubation or awake blind nasal intubation, and whether you have a normal front of neck anatomy to succeed in case if you fail, whether you can do a emergency cricothyroidectomy and maintain ventilation, or you plan for an elective tracheostomy and go ahead with the surgery. So these are the 3 options that you have. One is awake fiber optic intubation or awake blind nasal intubation. Second is elective tracheostomy, and third is you try nasal intubation, and if you land up in any problem, you should be able to do a cricothyroidectomy and save the patient. So this is the 3 important things for which you should do the assessment, for which you must first examine the nostrils and find out whether there is adequate patency in the nostril. Then you must check whether the cricothyroid membrane is palpable and the cricoid cartilages, the tracheal rings are all easily palpable without any mass like thyroid swelling or lymph gland swelling present in the front of neck. And if these things are satisfactory, then you say plan, this is an anticipated difficult airway, isn't it?
Yes, sir.
And the patient has a TM joint ankylosis with very limited or restricted mouth opening. This is branded as an anticipated difficult airway. So you must have a plan for managing this anticipated difficult airway, and that plan can be what I told you earlier: nasal intubation, tracheostomy, or emergency cricothyroidectomy. So with that in mind, you should assess the patient. So you won't get any marks for writing whatever you know about how to assess the airway in a regular fashion with a full mouth opening, Malambatti classification. All this is not applicable. So that is the catch in the question which you have to understand. Okay?
Yes, sir.
So I will just show you the simple point that you have to write for this question. So there is not much to write in this except the points that I told you. So as I told Vidya, it is not necessary that you should always write 4 pages or 5 pages for every question that is asked in the theory examination. Okay, so you have to understand the catch in the question, and you have to think and write what exactly is required. So patients are evaluated. First of all, what you have to see is whether they have a unilateral or bilateral TM joint ankylosis by orthopantography or coronal computed tomography. So what is the difference between unilateral and bilateral TM joint ankylosis? Have you anesthetized any patient with TMJ problem? You are a post-BA student, isn't it?
Sir.
Have you seen a case of TMJ being operated?
Yes, sir.
So what? How will you identify by clinical examination whether it is a involvement of one TM joint or both the TM joints, unilateral or bilateral? So if you see what is this picture? This is called the OPG, orthopantogram. Okay.
Okay.
So in this picture, can you say whether it is unilateral or bilateral? Okay. Can you see this area and this area?
There is a gap between.
So this is the normal joint. Okay, so this is the head of the mandible with the coronoid process here. So this is articulating in the glenoid cavity, whereas here it is all fused. There is no such portion. So this is a right-sided TM joint ankylosis. Okay, so if that is in right-sided unilateral TM joint ankylosis, you will have some space, little bit of space between the upper and lower incisors. Whereas, and you can see this in this picture. Okay, so you can see the gap. This is the only gap that is present. The patient is asked to open the mouth fully, and the picture is taken. So this is all the gap that you get. Whereas if it is a bilateral involvement, even this gap will not be there. Both the teeth will be almost touching or overcrowding one over the other. Okay, so that is all TM joint ankylosis patients are well assessed for previous anesthetic problem, general appearance of face, neck, maxilla, and movement. This head extension and movement is very important, and to whether teeth and the oral hygiene is very important, because the teeth may be sometimes very lot of caries may be there because they cannot open and clean. The oral pharynx may be quite stinky. The oral hygiene may be very poor, and they may have nasal obstruction or nasal septum problem. Soft tissues of the neck may be very enlarged. Thyroid enlargement may be there. Recent chest or cervical spine radiographs for any gross anatomical distortion. So these are all the points or the anatomical locations which you have to take care of. The maxilla may be sometimes quite receding. The mid-facial resolution may be there. So holding the mask itself may be very difficult. So these are the airway assessment that you have to do. So don't write anything like a normal patient and start describing. It is not necessary at all. Okay.
Yes, sir.
So fiber optic intubation is the gold standard for these cases. So for that you require the assessment of the nose, the neck extension and flexion. All these things are more important. And clinical features of unilateral ankylosis will be facial asymmetry and on the ankylous side, the chin and mandible deviate towards the affected side. So for example, in this patient, right side is the ankylotic joint. So the whole jaw will be moving towards, the mandible will be moving towards this, because this is a normal jaw, normal mandible. So the length will be normal. So this will be contracted and though it will move towards the affected side. And the unaffected side is elongated and flat due to normal growth. Restricted mouth opening will be there. Posterior crossbite of the affected side with class 2 malocclusion and reduced growth of mandible on the side of deceased. And so this is, can you see this picture? So this is a normal chin. You can see the whole mandible looks quite normal. Whereas this portion, this right side is the ankylosis side. So you can see the chin, when he tries to open the mouth, the whole chin moves towards the right side. Okay. So this is a shorter mandible, so it pulls this way. So this is how and you can see hardly any gap here. So what you have to examine is whether he has a patent nostril. You occlude one nostril and ask him to blow through that, and ask him whether he is able to breathe comfortably through both areas, and then examine the neck for any anomalies there. And bilateral joints are class 2 malocclusion, restricted mouth opening, macrognathic mandible with symmetrical bird face like deformity, and the impacted teeth due to macrognathic mandible, anterior open bite is seen with protrusive maxillary incisors, and these are the pictures. Again, this is a unilateral ankylosis. You can see the deviation here, whereas in bilateral, both the sides, hardly any opening of the mouth. And the both sides face looks similar because both sides are affected. The growth is restricted, so it looks like a normal face, whereas here it becomes deviated to one side. So unilateral and bilateral. And this is the CT scan of that, computerized tomography of the TM joint ankylosis. And so here the blue circle shows the bony fusion, the lateral part of the joint. And the red circle is the atrophic condylar process or the head of the mandible, rudimentary joint space. And the green arrow shows the bone mineral density morphology and non-bony fusion areas. And the white arrow indicates excessive bone formation around the joint. Okay, so these are the changes that you have to remember. So the answer will come to hardly 1 to 1.5 pages. That's all. You don't have to write too much. You have to first to say that it is an anticipated difficulty airway, and the idea of securing the airway for surgery will be only by 3 approaches. One can be by nasal intubation, either by using a fiber optic scope or a blind nasal intubation. The second option is an elective tracheostomy. Third option is a cricothyroidectomy and ventilation in case of emergency. So based on these 3 methods of managing the airway, I would like to examine the nostrils and the nose for patency and a non-obstructed nasopharynx. Then I will check for the visibility of all the thyroid cartilage, the cricoid cartilage, cricothyroid membrane, the tracheal rings, and rule out any soft tissue or thyroid swelling in the front of neck, and assess the patient for these 3 things. So this is how your answer should be mentioned. Okay.
Yes, sir.
So don't waste your time in the exam by writing about the 1, 2, 3 test, Malamadi test, all these things.
Yes,
This
sir.
all required only if a general question on discuss the method of assessing the airway without mentioning any pathological conditions. Then you can go ahead and describe all those things what we have read in the regular assessment. But in the case of TMJ, these are all the points that you have to remember. Okay.
Yes, sir.
Shall we stop here? Other 2 questions which have to be, which are sent, I think Jay Bharti sent her answer, but Sagar, did you send your answer? Sagar Avachar, is he there? Dr. Kamakshi sent me only Jay Bharti's answer on diabetic foot management, and there was no answer regarding daycare challenges, daycare anesthesia challenges. So now, for want of time, I will not discuss that. We will think about discussing that in the next class when we discuss the other questions. Okay. Who is conducting the show now? Jay Bharti, are you there?
Okay, sir.
Shall we will discuss your answer next class.
Okay, sir. Sure, sir.
So we will plan
Actually,
for the
Sagar sir
questions.
has also written the answer, sir, but he has written on pheochromocytoma. He wanted to study and he has written the answer and he has sent it.
Okay. That's what I was thinking why pheochromocytoma answer has come when the question is on daycare challenge, anesthesia
He
casualty.
wanted to study that topic and he sent that answer, sir.
Okay, then we will
Discussed with
discuss those two
Kamathi, sir.
questions
Yes,
along
sir.
with other questions next class.
Okay,
And,
sir. Sure, sir.
So any other questions or any doubts for anybody?